So I'm going to start by talking about this condition. So the technical term that we use is idiopathic inflammatory myopathy, shortened to IIM. Now, as I'll talk a little bit more in a few slides' time, IIM is a chronic autoimmune condition. It has multi-system involvement. Now, one of the most predominant manifestations we see is a muscle inflammatory process termed myositis. So throughout this talk, we might say IIM, we might say myositis. We mean the condition, and further on, when I am talking about the actual myositis itself, I'll give more details. So it's a rare condition. There's in the UK, around 10,000 people with this condition. It can occur at any age. So all the way from childhood, all the way through adulthood, all the way through to older age, the condition can occur. And once someone has it, they have it for the rest of their life. We currently don't have a cure. It has many different subtypes, which are listed here. So going from the top, we have the condition polymyositis, then necrotizing myopathy, antisynthetase syndrome, adult dermatomyositis, clinically apathic dermatomyositis, juvenile myositis, cancer-associated myositis, which I'll talk more about in future, and connective tissue disease-associated myositis, and inclusion body myositis. Now, all of these are different. They all have lots of different manifestations. They have different treatment responses as well. Now, one of the most common conditions you may well see is adult dermatomyositis. So this is a subtype where people have a muscle inflammatory process, so myositis. They also have skin manifestations. Antisynthetase syndrome is slightly different. So they have interstitial lung disease. They may have an inflammatory arthritis. They may have a degree of myositis, and a small number may have skin manifestations too. As the name suggests, clinically, amyopathic dermatomyositis is where people just have the skin manifestations, typically without the muscle involvement. Cancer-associated myositis, I'm going to talk more about in future. Connective tissue disease-associated myositis. So there are many people with systemic sclerosis or lupus or even Sjogren's who may have a muscle inflammatory process as one of the manifestations. So we typically wouldn't call them idiopathic inflammatory myopathy. They are people who have muscle inflammatory process, myositis, along with their connective tissue disease. Inclusion body myositis is within the IIMs, but slightly different. This is much more degenerative, has a different presentation, and typically occurs much later in life. We're not going to talk much more about inclusion body myositis, as it is quite different. So moving on to the basic science and pathogenesis. Now, in short, as with many other autoimmune diseases, there's evidence that suggests that there's a genetic predisposition and an environmental trigger. Now, what that environmental trigger is, we don't quite know. But for the genetic risk factors, we have some evidence that identifies some genetic associations, which I've listed here. So HLA 8.1 ancestral haplotype, the HLA-DRB1 0301, and HLA-B 08001 as well. There are some other genetic risk factors as well that influence T cell signaling and B cell signaling. There's an interesting study that identified the people who smoke and also have the genetic predisposition of HLA-DRB101 have an increased risk of developing anti-Jo1, which is a myositis-specific autoantibody, which we'll talk more about later on. Interestingly, there are a number of environmental triggers or risk factors, and it's always important to ask patients about this. So we do typically find that some patients will report a particularly bad infection before the onset of their symptoms. We don't know if that's a trigger for the actual pathophysiological process, or if it's maybe something that's unearths the symptoms. Interestingly, silica exposure has been associated with developing IIM as well. So it's always important to ask your patients if they've been exposed to silica, if they've been in the building trade, if they've been exposed, maybe one of their parents was in the building trade, for example. Certain medications, particularly statins, which are associated with a particular type of IIM, anti-HMGCR positive associated immune-mediated necrotitis and myopathy. There are some interesting studies that have identified that increased vehicle pollution, so people who live closer to major roads, have a slightly increased risk of developing IIM. This is also the case for a number of other autoimmune diseases. And there was a particular interesting study from China that identified that some people in China who lived close to fresh water were more likely to develop IIM, especially in the winter months. And we see this with some other autoimmune diseases as well, more likely to be developed during the winter months, indicating a particular association with common infections as well. So in summary, it's a rare condition, genetic predisposition with an environmental trigger, and there's more research needed in this area to fully identify this. Onto the actual pathogenesis of what happens in the patient. So we have most evidence for dermatomyositis here. So evidence indicates that there's immune complex binding to the endothelial cells. This activates the complement system. We then get cell lysis, reduced number of capillaries, leading to necrosis due to the reduced blood flow. And we see this across all IIMs. There's a mixture of an inflammatory process and necrosis as well. And many cytokines are involved here: type 1 interferon, IL-6, TGF-beta, etc., etc., etc. It's a complex interplay. We haven't fully elucidated how these all interact together. Many different cells are implicated in the pathogenesis as well: T cells, B cells, macrophages, dendritic cells, particularly in dermatomyositis. We see these in the perimysial and perivascular areas.
I really enjoyed your slide on pathogenesis, and particularly the environmental risk factor of smoking with one of the HLA associations with anti-Jo1. Two questions that I'll couch together. Do you think that myositis may be preventable? Could we delay the onset or even delay the initiation by modifying environmental risk factors? So that's the first question, and then I'll ask you a second afterwards.
So yeah, it's a great question we don't know the answer to at the moment. In a number of autoimmune diseases, studies have been done identifying people who have a positive autoantibody many years before the onset of clinical symptoms, so through big biobank and population studies. And they carried out studies seeing if instigating treatment or amending risk factors can amend the onset of clinical features. This hasn't been done in IIM. It's a fascinating area. Could reducing smoking, could reducing statin exposure, for example, could prohibiting the environmental infection, could that be the thing that could then remove the trigger and allow people who have the genetic predisposition to never develop the clinical features? We don't know the answer to that. It would be great if we could. It's a great area of future research, definitely.
So my second question is related but more clinical. What do you tell people when they ask you, how did this happen to me?
Yeah, great question. So whenever patients ask that, I always say you likely have a genetic predisposition. There's been an environmental trigger. We don't know what that's triggered it. Some patients are worried that they've done something and they feel guilty about it. They want to blame themselves. I say, well, in most cases, there isn't anything that anyone's done that's brought this on. Obviously, someone going on a statin, we could argue that that's triggered it. A lot of patients are worried that their children or their relatives are going to develop this when we say that there's a genetic predisposition. Studies have shown that there's a slight increased risk within the families of people developing IIM, but we don't yet know if family screening for any of the genetic abnormalities or any preventative treatment is going to actually impact the onset of IIM. So that's definitely, another great area of future research.